Mr. Chairman, the most active exchange during this budget debate has been over fiscal policies. Saving as a nation or budget marksmanship, temporary vouchers versus structural support, increasing GST earlier or later. As Health Minister, I feel I have a duty to somewhat weigh in. Chairman, in the course of my speech, may I display a few slides on the LCD screen?
Yep, go ahead.
Thank you. When I first joined this chamber 10 years ago, 2015, government annual health budget was about 9 billion. I was Minister for Education, I was second, 12 billion. I thought MOH very far behind, 9 billion. This year's healthcare budget is 21 billion on the right, moved to second behind MINDEF. By 2030, it is estimated to be over 30 billion, at least another 10 billion increase. In comparison, a 2 percentage point increase in GST gives us about $5 billion more in revenue today. We need the additional GST revenue, paid for mostly by those who are better off, foreigners, tourists, to continue to support universal and affordable healthcare for Singaporeans. The support given in healthcare is practically all structural instead of vouchers. We can argue about the perfect timing for raising tax revenues. However, if we do not raise the revenue in time, while the population ages and healthcare expenditure escalates, we won't be debating budget marksmanship then. There wouldn't even be a balanced budget target board to aim for, as our fiscal position will be deep in the red. That said, we cannot let the healthcare expenditure curve escalate uncontrollably. It is a bill that all of us ultimately have to pay, as taxpayers, as patients, or as insurance policyholders. But it is very difficult to rein in escalating healthcare expenditure, especially when it is a matter of life and death for ourselves or for our loved ones. Further, all around the world, people have high expectations of public healthcare system. Our three biggest wishes are for healthcare to be available when we need it, of high quality, and affordable. I have spoken about these objectives in earlier COS speeches, but let me talk about our plans in the coming few years for each of these objectives. First, affordability amidst rising costs and inflation. Dr. Lim Wee Kiat, Mr. Yip Hong Wing, Ms. Mariam Jaafar, and Ms. Hazel Phua asked about this. We therefore have the S+3M framework, government subsidies, MediShield Life, MediSave, and MediFund, S+3M, to cushion patients from healthcare cost increases. Today, 7 in 10 patients in subsidized hospital wards pay nothing out of pocket, zero, while 8 in 10 pay less than $100. We constantly review and enhance the S+3M framework to adapt to emerging clinical practices and also new circumstances. Last year, we updated income thresholds to allow up to 1.1 million Singapore's residents to qualify for higher subsidies. A few months ago, we announced significant adjustments to MediShield Life to better protect Singaporeans against major hospitalization episodes, and then defray costly outpatient treatments like dialysis. Most recently, we announced subsidies and MediSave withdrawal for vaccination against shingles. Today, I'll talk about further adjustments that we are making. One, I start with MediSave withdrawal limits for outpatient scans. Over the years, MRIs and CT scans have become more commonly used for diagnosis of certain conditions, such as cancer, as they are more detailed and accurate than X-rays. But they are also more costly. So to ensure these remain affordable, we will double MediSave withdrawal limit for such outpatient scans from $300 to $600 per year, starting in 2026. Next is Flexi MediSave. A few MPs have asked about this. This scheme provides seniors aged 60 and above the flexibility to use their MediSave for outpatient treatments at polyclinics, public specialist outpatient clinics, as well as CHARS clinics. This limit was last raised in 2021 from $200 to $300. Since then, outpatient medical needs have grown further. We will therefore increase the withdrawal limit to $400 per year from the fourth quarter of 2025. Dental health is another area where affordability is becoming a concern. Several MPs have raised this and asked if oral health can be part of Healthier SG. Actually, preventive dental care predates Healthier SG. All of us remember in primary school, the dreaded moment the dentist nurse comes in and calls your name. That was preventive care, long ago, yeah. There has been a long collaboration between MOE schools and MOH to protect the teeth of the young. However, in adulthood, oral health deteriorates. Generally, a person needs at least 20 natural teeth to chew effectively. Unfortunately, only about half of our older population have them. We will take further steps, therefore, to encourage preventive oral care and hopefully preserve more teeth. Currently, only Pioneer Generation, Merdeka Generation, and CHARS Blue card holders enjoy subsidies at private dental clinics for preventive procedures, such as scaling, polishing, and filling. We will extend subsidies for these dental procedures to CHARS Orange card holders. I've met many residents, and this includes my own CCC chairman, who suffered from tooth decay and then decide to extract their tooth. I asked them, why don't you save the tooth? It can be done via a root canal procedure, which is quite common now. This means the dentist will remove the decayed parts of the tooth, including the nerves in the roots of the tooth, and then cap it, and then fill it up, and then cap it with a protective artificial crown. The tooth is therefore saved. It adds to your 20 teeth. 20 teeth includes those that you save. They say no, because extraction was cheaper and it involves fewer trips to the dentist. But this is penny wise and pound foolish. We will have fewer and fewer teeth as we grow old if we take this approach. This diminishes our ability to chew effectively and in our old age affects our nutritional intake. We will therefore increase the CHARS dental subsidy limits for restorative procedures such as root canal for Pioneer and Merdeka Generation, as well as CHARS Blue and Orange card holders. We will also allow Flexi MediSave to be used for costlier treatments like root canals and permanent crowns at CHARS dental clinics and public healthcare institutions. The next slide shows the net impact for a typical Merdeka Generation card holder, someone with a tooth decay but decide to save it. For this senior, a molar root canal after subsidy costs $700, about $700 at a CHARS clinic, that's the leftmost column, which he must pay by cash today. After the subsidy enhancement, the out-of-pocket payment will be about halved to $370. He can also use up to $400 in Flexi MediSave, so there may not be any cash payment required. And that's the rightmost column. When subsidy goes up, we must prevent some providers from raising prices sharply and creaming off the subsidy. We will therefore have to strengthen governance to prevent abuse by introducing fee benchmarks for common dental procedures. So MOH will follow up with this. Both the enhancements and fee benchmarks will be implemented around the fourth quarter of 2025. Use of Flexi MediSave will be effective sometime in the middle of 2026. The final area is long-term care services. The Prime Minister mentioned this in the budget statement. So let me elaborate a bit more. Long-term care is for seniors who have become frail, disabled, and dependent on others to carry out daily activities such as eating, showering, or changing. They are cared for in two main settings. One is nursing homes or at home, with support from community and home care services. Mr. Xie Yaoqian asked if there could be fee caps for these services. In fact, both services today are heavily subsidized by government, with co-payment by users. With an aging population, our annual national long-term care operating expenditure has almost doubled over the last 5 years, from $1.7 billion to about $3 billion today, and continues to rise. And this is because as one gets older, our care needs intensify. There is also considerable upward pressure on fees. This is mainly driven by manpower costs, especially post-COVID, where salaries of healthcare workers globally were reset to a much higher level. To ensure affordability, MOH has been increasing funding to support nursing home providers, while also quietly imposing caps on fee increases for existing residents. We did not announce this, but quietly we've been doing that to keep fees low. So nursing home providers also absorb part of the higher costs for these existing residents. As for seniors newly admitted to nursing homes over roughly the past 1 year, they have been paying higher fees, and this can be a financial burden to the families. This arrangement is not sustainable. It is also not fair to the providers, most of which are charities. So it is time for us to improve our subsidy framework and significantly expand our structural support for seniors and their families. The next slide illustrates the changes we are making. The left side is nursing homes. The right chart is for home and community care subsidies. The x-axis on each slide is the per capita household income bands, while the y-axis is the subsidy percentages. The left chart, the white boxes show the current subsidy percentages. The blue and orange boxes are the additional subsidies. So you see everything moving up. So in short, we will, as indicated in blue, increase subsidies by 5 to 15 percentage points for almost all eligible households. Expand eligibility from maximum subsidy of 75 to 80% from about 2 in 10 to about 3 in 10 households. So you see the leftmost 2 columns of each chart are now of the same height. So the maximum subsidy is now expanded to a larger group. Provide additional subsidies of 5 to 15 percentage points as indicated in orange for those born in or before 1969, as seniors in these cohorts are not well covered by MediShield Life. And expand eligibility to cover from 6 in 10 today to about 7 in 10 households, so more can benefit. The increases in subsidies will be effective from July 2026. It's a while from now, more than a year from now. So between now and then, we will provide interim rebates, which will keep the fees low for Singaporeans using long-term care services. Similar enhancements will apply to community dialysis services too. We will also increase the home caregiving grant and expand the coverage of the Seniors Mobility and Enabling Fund as announced by the Prime Minister in the budget statement. The enhancements for these schemes will be implemented progressively from January 2026. With these enhancements, over 80% of seniors, especially those being cared for at home, will pay less for their long-term care services. Let me illustrate with 3 examples. Example 1 is a lower-income family supporting a moderately disabled grandpa receiving home and community care. They pay about $600 a month today. In 2025, the interim rebates kick in, and their out-of-pocket payment will drop to about $500. In 2026, when the full enhancements are implemented, it will drop to $200. Thereafter, fees will continue to rise in tandem with inflation and income. Example 2 is a lower-income family who recently admitted their severely disabled grandma to a nursing home. The monthly out-of-pocket payment now is about $1,300. In 2025, when the rebates kick in, this will decrease to $1,150. In mid-2026, when the full enhancements are implemented, payments will further drop to about $1,000. Example 3 is a disabled grandma from a lower income family who has been staying in nursing homes for a few years now. Instead of $1,300 a month, today they pay a discounted amount of about $900 because MOH caps their fee increases. The upcoming enhancements will formalize this temporary arrangement. We will continue working closely with providers to manage the fees that families have to pay. We should not change much this year. Over time, their fees should rise gradually in tandem with inflation and income. The entire package of long-term care enhancements will benefit more than 80,000 seniors who can expect to receive support of up to $2.1 billion from 2025 to 2030. Chair, let me move to the second objective of public health care, which is to ensure availability. Post-COVID-19, like many countries in the world, we saw many more seniors with complex conditions. A couple of years of isolation and neglect of chronic conditions have taken their toll. The average length of stay in hospitals jumped abruptly from 6 days to 7 days post-pandemic. Sounds like one day, but it means a 15% increase in workload for hospitals. Worse still, COVID-19 delayed our infrastructure development. We have been doing major catch-up in infrastructure development. Expanding capacity, however, does not mean just building hospitals. We need smart capacity across a spectrum of care needs, and especially in the community. Only then will we be able to give the most appropriate care for different types of patients. Over the past 5 years, we have expanded capacity by over 6,300 beds, as shown on the slide. This includes 1,200 acute hospital beds with the opening of Woodlands Health and across other hospitals. This is the part in white. We rolled out mobile inpatient care at home and commissioned 200 beds. We opened new community hospitals and added 600 new beds. And we also added 4,300 nursing home beds. And adding nursing home beds is a major move because if a senior cannot find a nursing home bed, they'll end up in a hospital. This capacity makes a huge difference. With Woodlands Health, the capacity crunch at Khoo Teck Puat Hospital has finally eased after many years. Bed occupancy has fallen from the typically 100% or more to now a healthier 85%. Average waiting times have thus fallen. Recently, and not many people know this, the Singapore General Hospital opened an 80-bed acute medical ward to support its emergency department. It caters to patients who have suffered, say, a fracture, or you met with an accident and you're in shock. So they are not in any danger, but they just need a short stay in hospitals. So this acute medical ward catered to this kind of patients and immediately provided relief to the ED, the emergency department. During COVID-19, SGH had to convert this link bridge between two blocks into bed space for ED patients that overspill. And no more space, we put them along the link bridge. Not many people know that. Wu Ming know that. The beds were recently removed, and the bridge is now open to pedestrians again. And one of the final harrowing memories of COVID-19 has now been removed from SGH. From 2025 to 2030, we plan to add another 13,600 beds to our system. This includes about 2,800 public acute and community hospital beds to be added to SGH, Changi General Hospital, Sengkang General Hospital, and also Woodlands Health. It will also include beds in the redeveloped Alexandra Hospital and the new Eastern General Hospital, which will open progressively from 2028 and 2029, respectively. This will bring public hospital beds from 12,000 today to 15,000 in 2030. That's a 25% increase. We will also add around 10,600 more nursing home beds. That's a huge number. That's a huge number. But that's the number that we have to deal with as our population ages. In the following decade, from 2030 to 2040, the new Tengah General Hospital will open. Singapore General Hospital campus and the National University Hospital Cambridge campus would have undergone major redevelopment to further improve national healthcare infrastructure. The third and final objective is to ensure high quality. This means that illnesses are effectively treated, patients' preferences respected, innovative technologies leveraged to ensure patients can recover and get back to health quickly. The intangible aspects also matter. Kindness and care must fill our wards and clinics so patients do not feel alone in their journey of convalescence. When a patient nears end of life, we walk the last mile with them and ensure that they leave peacefully. What matters most to quality is actually our people. Our healthcare workers, they are the driving force behind good care. We saw that during COVID-19, and they deserve all our respect, our appreciation, and encouragement. We are not doing badly in retaining and attracting talent. We are fortunate that Singaporeans want to join the healthcare sector. Our healthcare education programs see healthy intakes. I always say if you go to a primary school, for every 15 students, young students you see, one is likely to join healthcare. For every 20 students you see, one is likely to become a nurse. Regionally, we are an attractive place for foreign nurses. We worked with the Singapore Nursing Board to significantly reduce the processing time of registration applications from 6 months in the past to now 30 days. We moved exams online, and with these moves, we become even more competitive. In 2023, we recruited about 4,500 new nurses. Last year, we continued this momentum with another 3,800 new nurses and introduced the Angel Scheme, the Award for Nurses' Grace, Excellence, and Loyalty Scheme. And that was introduced in 2024 to encourage nurses to continue viewing their profession as an attractive long-term career. Over Chinese New Year, I also announced salary enhancements for pharmacists, allied health professionals, administrative and ancillary staff later this year, and about 37,000 staff will benefit. Doctors are another key area. We have increased the intake across our 3 medical schools from about 500 in 2020 to 550 in 2024. We have expanded the list of recognized overseas universities so we can welcome more Singaporeans studying medicine overseas to return to Singapore to practice. Our healthcare workers, including junior doctors, they are dedicated and they work very hard. Heavy workload is a phenomenon in all developed countries, which are aging and experiencing rising patient load. Mr. Faisal Manap spoke up about the difficulty that junior doctors are facing. I thank him for caring for our doctors. But let me state a few facts. Number one, Employment Act does not cover PMEs, including doctors. So the hours that you mentioned doesn't apply. I think many PMEs, including MPs in this house, we work quite a number of hours beyond what is specified in the Employment Act. So that's number one. Number two, I hope members do not go away thinking that we are facing a major outflow of doctors. Our attrition post-COVID is about 7%. It is healthy. I wish it can be slightly lower, but actually it's quite healthy. Thirdly, salary adjustments for doctors was implemented 1st February 2024, only recently, and we try to make sure we are competitive. I want to emphasize, MOH has cared for our people and invested in them heavily for decades, from the moment they enter medical school. The subsidy we provide, the investment we provide to our talent when they come into the system, going through housemanship, as junior doctor, going through residency, we invested heavily. We continue to invest heavily in our doctors. So in championing for the welfare of junior doctors, I urge Mr. Faisal too to consider the interests of patients. Remember, healthcare is not like aviation. When pilots need to rest, passengers do bad. You just have to wait for the next flight. All of us have experienced that in airports before. If we do that for doctors, patients will be left untreated, and their lives can be in danger. So for MOH, we constantly have to balance the welfare of healthcare workers as well as patients. If we suddenly limit the working hours of doctors, patients will suffer. There have been many efforts for us to better manage these tensions, which SMS Dr. Janu Putticherry will elaborate on. Transformation of our medical workforce is key to maintaining and improving quality of care. The profile of our patients are changing, generally older, with multiple health conditions requiring simultaneous management and coordination. We are therefore reorganizing the healthcare workforce. This means complementing specialists who are very skilled in managing specific organ systems with doctors with a broader breadth of expertise who can anchor, coordinate, and manage cross-specialty issues for patients, which Dr. Tan Wu Ming talked about. This will enable us to deliver more holistic and integrated care, and it will be a key priority in the coming few years. Besides the organization of people, the ingenuity of our people matters just as much in driving quality. Technological breakthroughs like AI and genomics are ushering a scientific revolution in healthcare. Dr. Lim Wee Kiat spoke about this. We are now working on new legislative protections to safeguard the use of genetic test information. And these are important and sensitive personal data. In my view, these data should not be used to decide on issues such as insurance underwriting, for hiring people, or granting of university places. But we will need broad public consultation for this legislation. Such a law is important to anchor the moral foundations of our society, even as medical science breaks new ground. With sufficient legal assurance, we will have the confidence to actively explore and experiment with the use of technology. Finding the right use cases is critical, and we are not waiting for the legislation, we are starting now. In fact, we started some time ago. Many good applications are emerging. SGH is deploying an AI-powered app for parents to screen their babies for jaundice at home using their handphone with an app. The app is trained with Singapore's multi-ethnic data and is sensitive to different skin tones. At NUH, doctors use AI to recommend treatments for patients by tapping into a vast database of historical caseload. And with this tool, some doctors quip that a junior doctor can now perform almost at the level of a senior doctor because the experience is granted to them through the AI. In all these projects, the healthcare professionals remain in control of patient care and are enabled and enhanced by AI tools. When application is workable and is effective, we will expand it throughout the healthcare system. Hence, by the end of this year, we hope all public healthcare institutions will adopt generative AI systems that can automatically transcribe doctors' conversations with their patients, summarize them for doctors' review before they are entered into the patient's healthcare records. By end of this year too, we hope all public health institutions will be able to use AI to automate and improve the accuracy of imaging scans, such as chest X-ray and mammograms. Mr. Ang Wei Neng and Ms. Ng Ling Ling asked about TCM. The quality of our system can also improve if we can successfully integrate aspects of TCM proven to be safe and effective to complement Western medicine as part of mainstream healthcare. Singapore is a multicultural country, open to learning from all parts of the world. If there's a jurisdiction outside of Greater China that can blend and integrate Western medicine and TCM, it should be us. We made a lot of progress in recent years. We now have our own TCM degree delivered by NTU, enhanced professional training, we streamlined the examination requirements, and we are strengthening the TCM accreditation framework. Today, certain acupuncture treatments are already incorporated in mainstream public hospital treatment. Later this year, SingHealth, and the Academy of Chinese Medicine, Singapore, will be co-organizing a forum on integration of TCM and Western medicine. It will be attended by both TCM practitioners as well as Western doctors. I think it will be a great platform to explore further opportunities and to identify further steps to synergize the strengths of both systems. Mr. Chairman, my speech now in Chinese. 对年长者来说，一个主要的担忧就是医药费。他们大多数已经退休了，靠储蓄过生活。当需要动用储蓄来支付医药费的时候，难免会担心他们负担不起。因此，我们多年来推行了许多政策，包括了建国一代和立国一代的配套、健康 SG 和乐龄 SG 的计划，来减低年长者的医药费负担。去年我们调整了社保援助计划，就是 CHARS 的这个资格标准，让更多人的橙卡能够变成蓝卡。我也刚宣布了几项新的措施。第一，提高灵活保健储蓄计划，就是 Flexi Medisave 的使用顶线，从每年300元增加到400元。第二，提高一些牙科服务的津贴额，国人也可以开始动用保健储蓄来支付根管治疗和牙冠梗的手术费用。第三，调高长期护理服务的津贴。国人时不时都会向卫生部建议提供更多的津贴，我们都能理解，合理可行的我们会尽量的采纳。但大家也应该听过“羊毛出在羊身上”，无论是更多的津贴、更多的保险赔付，甚至免费服务，钱总是要花的。钱就跟羊毛一样，最终还是由人民通过付费、保险费或税收来承担。所以我们是通过津贴、保健储蓄和自付费用多管齐下，继续减少资源的浪费，尽量避免不必要的疗程或者是过度的治疗。这能够约束国家的医疗开销的膨胀，人们的负担也会相对的受到控制。对大多数人来说，确保自己付得起医药费，最佳方法就是保持健康的生活。身体健康，远离疾病，是约束医疗费膨胀的最重要的方法。因此，我们推行了健康 SG 计划，许多国人踊跃的参加，更多国人也开始多做运动，这点我感到非常的欣慰。今天，我希望能够说服更多的年长者保持身心活跃。年长者除了做运动之外，还要有社交圈，让欢笑围绕自己。所以我们用心良苦，在全国各地设立了活跃乐龄中心。我们为这些中心提供更多的资源，让他们为年长者能够举办更多的活动、更多的聚会。在我的选区，我是活跃乐龄中心的忠实推销员。我在这方面也取得了一些心得。邀请年长者来到我们的活跃乐龄中心，有一点像三顾茅庐。当年长者第一次听到活跃乐龄中心 AAC 的时候，他们会感到好奇啊，他们会问这个是什么中心，是谁办的？他可能会问义工，你是不是房地产代理？但我们进一步解释的时候，什么是活跃乐龄中心？他们有做什么活动？年长者的态度往往会越来越开放。如果我们接着跟他们说，中心每个星期都有聚餐，你来，我们请，我们总能够看到他们脸上露出的喜悦和笑容。古时候呢，武林高手为了得到功夫的秘籍啊，你争我夺，自相残杀。现时今日，我们需要的是不是武功秘诀，而是健康秘诀。健康秘诀呢，大家垂手可得。 吃得健康，睡得够，多做运动，定期做体检，有空就来 AAC 来我们的活跃乐龄中心走走，这就是健康秘诀。Mr. Chair, let me conclude. I spoke about our plans to achieve our three big objectives of public health care. The problem is that they are competing objectives, a trilemma. It is impossible to achieve all three fully. Something has to give. Indeed, in the UK, patients don't have to pay for public health care. But as a result, demand shoots up, and they now have 7 million public patients on the waiting list for elective treatments. Healthcare is available, but not so. Healthcare is affordable, but not so available. Dr. Lim Wee Kiat mentioned what can we learn from other countries, including NHS. What we can learn from NHS, try not to be in their position. Yeah. Switzerland adopts novel medical technologies and ranks top in the world for quality. But about a quarter of the population chooses not to be treated, citing high cost. Hence, high-quality healthcare in Switzerland, but not so affordable. These countries offer an important lesson. If we are dogmatic and want to achieve one objective 100%, we pay a big price in the other objectives. But if we take a more practical approach, we can balance the trade-offs and try to maybe achieve all three at 80%. A key to achieving these lies in a healthy population. With better health, we can achieve all three at the same time without trade-offs. Mr. Chair, Dr. Lim talked about healthy longevity. A friend of mine in his 70s, and he's an avid golfer, he once said that the perfect way for him to go is when he is 100 years old, playing golf, hit a beautiful shot, score a hole-in-one. He's so happy, he collapsed and died. He may sound like he's joking, but I think he's dead serious. No? What he essentially described is the holy grail of healthcare, where health span equals lifespan, and you are healthy enough to do what you love until the last day. We are far from that scenario. Singapore, indeed, has one of the highest average lifespan in the world at 84, but our health span is only 74. This gap is quite consistent with most developed countries, but we must try to narrow it. We need policies that improve population health. Individually, too, we can all practice better preventive care and take better care of our own health. Nationally, we need a major program, hence Healthier SG. After 1.5 years, we enrolled almost 1.2 million Singaporeans onto Healthier SG, about half the eligible population. 3/4 of our enrollees have also since completed their health plan consultation. Health screening, vaccination rates, they are all rising. Discernibly, more Singaporeans are exercising, and we are happy with this good start. A lot of hard work lies ahead. We are inculcating more good habits amongst our population. We have cut down sugar consumption, including the members' room. We are labeling packaged drinks. People are much more conscious. We are moving soon to sodium and saturated fats. We implemented GrowWell SG to improve health habits of our young. We are tackling the mental health challenge. And at some point, AI models will analyze our medical or even genetic data to predict 10 years ahead if we are likely to get a stroke, a heart attack, or cancer. And then it will alert our Healthier SG doctor, who will in turn advise us what are the preventive steps to take. This is predictive preventive care, Healthier SG 2.0, and we are not far away at all. Mr. Chairman, we are determined to expand healthcare capacity. So even though we are rapidly aging, healthcare must be available when Singaporeans need it. We will develop our people, transform medical delivery, and harness technology to continue to deliver high-quality healthcare that Singaporeans deserve. Through our S+3M framework, we will ensure no one is denied appropriate medical care because they cannot afford it. This government understands that healthcare is a basic and essential public service that Singaporeans value. We have the experience, wherewithal, determination, ideas, and policies to upkeep and strengthen this key tenet of our social compact. Our agenda for healthcare is transformative and long-term and will take us well beyond this budget year. I hope to have the continued strong support of this House as we work together to overcome the mounting challenge of an aging population, to cure sickness, to bring comfort to those in need, and strengthen the health and happiness of all Singaporeans. Thank you, Chair.